When you look at our hospital, we're really like 65% of our inpatients were over 65. So there was a real need to provide somewhat of a specialized care unit for the majority of patients that we see. So there was a lot of research and evidence done, and a lot of advocating with the community and the foundation to be able to change this space into an acute care of the elderly unit. I was brought in about a year before we opened. We looked to a lot of other ACE units within the region and outside of our region because we were one of the first ones in Ontario to have an acute care of the elderly unit, to look at design and what it might look like. And of course, this was designed for a future with the big hallways, the private rooms. So there was already a good design element for this unit. We had a team pulled together. I was the inpatient clinical lead. There was a clinical nurse specialist, and we worked with the architects, which was a really innovative thing to do at the time. It was great to be able to get that clinical view when we're actually designing a unit and using the senior-friendly philosophies that we needed to use. So it was a great collaboration between clinical and architect. People would come over here and say, it's almost like a different hospital over here. We looked to a document called Code Plus, which is a sort of a best practice for senior-friendly design. And a senior-friendly hospital is really an everyone-friendly hospital. We always say that. Some of the design elements when you come into the ACE unit, our lighting is no glare lighting. Our lighting is all off to the side and not overhead. There's no designs on the floor. A lot of elderly people, especially with cognitive changes, see those designs as holes, and they could be a fall risk. So there's no design, much to the architect's dismay. They like to have all these curly cues on the floor. The handrails are deliberately a different color to contrast with the white walls so they can be able to see them. There is automatic lighting in the bathroom, so if you're walking in with a walker, you don't have to feel for the light. It automatically goes on. Every room has natural light in it, which is really important. We have a sleep hygiene policy here as well, and the private rooms really promote better sleep. At that point in time, Kathleen Wynne was our premier. She had supported the funding for the unit. We also had a lot of our staff here, Dr. Fraser Miller and Kathy Gray, who really spearheaded the vision for this unit. So we had a great celebration. Everyone got to view the space, the foundation, a lot of donors, and of course, can't be remiss in saying the Myers family was here. So, thanks to the Myers family, this was well funded. It was very nice, a nice opening. We had a lot of orientation sessions prior to opening, scavenger hunts. People could walk around and find stuff. Also sort of help the staff understand that although it's a huge unit, it's really can be divided into 3 smaller spaces. The design is such that there is a medication room, a team station, and a supply station in each one of the little wings. So they act almost as separate little units. So it took a bit of adjusting, but once the staff got over here and got used to it, they really enjoyed it. When we first opened, we did have a very, I think one of the differences over here is we hired permanent allied health personnel. They stayed with us. We became a really good cohesive team and really focused on those senior-friendly practices, healthcare practices, looking at their function, mobility. We had a really wonderful program with volunteers called the VIBE program, volunteers involvement benefiting elders. They did a little bit of help the patients with videos. So it was a real team effort, and the patients really benefited from that. Knowing the team, being comfortable with them, and having not just nursing look after the patient, but the whole team. So putting in our processes for sleep, for mobilizing, looking after patients' cognitive decline, looking after their functional abilities, we were able to actually get them back to their home faster and more often than if they were on a general medicine unit.